So, as it is just 2 minutes past, I want to get going because I want to be respectful of everyone's time, but I would just like to say I'm so excited to welcome Dr. Simon to our CWRH Friday seminar. I originally got to know Dr. Simon through our previous association, the WRHA, plus we kind of travel around similar circles as well. A little background about Dr. Simon. She did her OBGYN residency at Yale and then did a fellowship in family practice and reproductive health at Northwestern University, where she currently is. I would love to see that you did that little mini geriatrics training at Johns Hopkins. I know John Burton very well. I've gotten to know him over the years, and so pleased that you're in that circle as well. Melissa is the George H. Gardner Professor of Clinical Gynecology, Vice Chair of Research in the Department of Obstetrics and Gynecology at Northwestern University Feinberg School of Medicine. She's also the founder and director of the Center for Health Equity Transformation and the Chicago Cancer Health Equity Collaborative. She serves as the Robert H. Lurie Comprehensive Cancer Center's Associate Director for Community Outreach and Engagement. She's an expert in implementation science, women's health across the lifespan, minority health, community engagement, and health equity. She's been recognized with numerous awards for her substantial contribution to excellence in health equity scholarship, women's health, and mentorship, including her recent election to the National Academy of Medicine and the Association of American Physicians. She has received the Presidential Award in Excellence in Science, Mathematics, and Engineering Mentorship, and is a Presidential Leadership Scholar. She's a former member of the U.S. Preventative Services Task Force and serves on the NIH Office of Research and Women's Health Advisory Committee. Taking a look at her voluminous CV, recently she was involved in a JAMA paper that was published last year, Actions to Transform U.S. Preventative Services Task Force Methods to Mitigate Systemic Racism in Clinical Preventative Services. So again, Melissa, thank you so much for taking the time to speak with us today. We're very excited about hearing about the intersection of implementation science, community partnership, and health equity to improve women's health. A very, very timely topic. Thank you.
Thank you so much for that way too kind introduction, Holly. That was amazing. It is awesome to be here. I am bummed that I cannot be in person, not only for the weather, but for the amazing collegiality and friends. And so thank you all for inviting me and spending this Friday afternoon hour with me. I really appreciate it. I'm about to share my screen and I'm about to play from start. All righty, let's go. I hope to be able to end in time to invite questions, because that's where the learning actually happens. I wanted to give you not a formal lecture or deep dive into one topic, because really what I want to do with the work that I do is invite other people, because we need more people, to really think about ways in which research can go and should go, especially with respect to advancing health equity. And it's got to go there. It's got to be entrepreneurial. It's got to be innovative. And I'm kind of going to walk you through a bunch of things that hopefully will spark some light bulbs in you. And again, I always enjoy follow-ups, so you can email me or contact me in any way that's good for you, because that's how we move things forward together. It's a team sport. So we're going to define some health inequities, describe design thinking approaches to include implementation science and how they apply to understanding health inequities, illustrate some examples of structure and design that promote disparities in research, and apply design thinking to some of my examples in Chicago on the ground. Okay, so let's start with some definitions and framing, because I don't assume that everybody's on the same page or everybody has the same level of knowledge in the audience. So the cell, y'all learned this in maybe middle school, junior high, things like that. I know my kids, I have 4 of them. They all had to make some part of the cell in various ways, shapes, and forms, including plaster Paris. What a mess that was on my dining room table. The cell is a structure that has a lot of parts, and those parts need to be functioning correctly. And not only do they need to be functioning as individual parts correctly, but they need to orchestrate. And so architecture and design and that synchrony of movement and interaction is really critical to making a cell work, right? We also know that we can design with all of our fancy science now and our fancy engineering and all of those advances. We can design super fancy widgets to make some really cool stuff, right? We can put people in outer space now that haven't trained for years. But if we don't have the right diverse set of people and lenses and perspectives at the table, the widgets that we design will not translate well to all the populations that could benefit from them or that need to use them. So that's, you know, the imperative for DEI work, diversity, equity, inclusion work. That's the imperative for having diverse teams, because otherwise, garbage in, garbage out. And that's a really important point. We always have to look under the hood of the car. All right. I implore you to always think about what is that structure and design that's further upstream that caused the phenotype that we see today. And with anything that can be applied to a policy, it can be applied to a healthcare practice, it can be applied to anything really. And so we really have to scrutinize all related processes and structures. And this clearly can be applied to the education pipeline. Like who gets to be a graduate student, or who gets to come and be a student at UAB and School of Medicine, or a resident in a certain program, et cetera, and a faculty member, right? And who gets promotion and tenure. So here's the definitions. Inequality, upper left-hand corner. So even though I have a tree as the example, most inequitable issues and structural issues are human-made and not organic like a tree. But this is the way I like to portray these definitions to make it easier to understand. So inequality means something, some rule, some policy, some practice, something that we do is fundamentally bent, all right? And it is fundamentally advantaging some people or persons or populations and actively disadvantaging others. In the upper right-hand corner, equality, you hear this a lot. We have equality. This is an equality framework. We have equality in this United States of America. Well, that means that we give everybody the same lift, so to speak, to get to the goal, which is the apple. But if the process or practice or policy is fundamentally bent, it's still going to favor one population or people and actively disadvantage others, regardless if we give everybody the same lift, the equal thing. In the lower left-hand corner, equity. Equity acknowledges that that tree is fundamentally bent, that practice, policy, et cetera, is fundamentally bent. And so in order to circumnavigate that bentness, we have to give everybody a different type of lift to get to the goal, which is to get to the apple in this picture in the lower left-hand corner. And so everybody needs a different type of lift, so to speak, to get to the goal. In a justice framework, which is where health equity work needs to go, because we've done a lot of describing of the tree being bent, so to speak. But where it needs to go is asking those fundamental questions, looking under the hood of the car and saying, whoa, why is the darn tree bent in the first place? Why is it bent? And how do we unbend that tree? And I say unbend on purpose because it is, you know, it's a process, right? And you can't just straighten up the tree, or do we have to plant a new one? And start over again. So there's a lot of considerations with that justice framework, but that's where we need to go. So I like to give Dr. Kamara Jones's definition of racism because I think it's really strong. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities and saps the strength of the whole society through a waste of human resources. Racism is a fundamental cause of disease, a root cause. It is baked into our systems and institutions, and it kills. So David Williams at Harvard in 2019 has a really great pictorial or figure in Health Services Research Journal. And this is the house that racism built, because a lot of people ask me, well, how can racism get under your skin? Well, there's different types of racism and experience of discrimination and bias. There's cultural racism, stereotype, stigma, biases. There's institutional racism, segregation, segregating laws, Jim Crow laws, things like that. And there's individual discrimination. And if you look in the basement of that picture, individual discrimination impacts, especially if over time, experiencing it over time, impacts effective reactions and appraisal, but it impacts your psychological responses, your biological processes, your behavioral responses, your healthcare use responses, your individual and collective, your community, your family responses, and that impacts health outcomes in many different ways. And that's where that translational science needs to go for health inequities, really to examine this basement. So now that we have reviewed some definitions, let's consider environments, right? Historic, because context matters, and social environments, built environments, physical activity environments, work environments, play environments, all of those environments matter to how our health, to our health in many ways. So we all know there's a deep and long history of slavery, racism, discrimination in this country, treating people as property. We know, unfortunately, in gynecology, we had Marion Sims with all of those vesicovaginal and rectal vaginal fistula and 12 enslaved women, Lucy, Anarcha, and Betsy, without anesthesia. We may know about 1917 and the bath riots, which was prompted by Carmelita Torres, who was a 17-year-old that refused to disembark from the bus and submit to the disinfection process that was happening as Mexicans were crossing the US-Mexico border. And that included disinfection with vinegar, kerosene, and gasoline. In the 1950s, the birth control pill that we use to this day was tested on Puerto Rican women, and Inovid was the pill, and they were given a very high dose formula, and they were not told that they were part of a trial, and 3 women actually died with no investigation. It's just really, again, egregious demonstration of how science and healthcare has abused people. Forced sterilization in the 1970s, and even forced hysterectomy in 2020 in the ICE detention centers in Georgia. So we've seen that COVID-19 has exposed existing health inequities, exacerbated them across the board, continues to do this now that we're shifting the pandemic more towards an endemic phase in this United States with the lifting of mask mandates. We're really putting the burden on our most vulnerable people in our country. And that's really important to understand as we move forward with policymaking, as we enter post-pandemic phase. Again, we hear a lot right now, and there's a lot of fervor and excitement around looking at social determinants of health. And here they are, those infographics around the circle, the oval, social environments, public safety, transportation, education, employment, housing, etc. And a lot of people are saying, oh, but we're collecting these data now in our EPIC or our electronic health record. Systemic racism still drives these. So if we're not going to the root cause of why the tree is bent in the first place and trying to look at where the tree is bent very intentionally and strategically and trying to unbend that tree, we're not going to fix the situation. it's really, we have two different cliffs, and I can say this in Chicago is very much so a tale of two cities. In Chicago, one of the most segregated cities in the country. And one cliff is where the green people are. They actually start at near the edge of the cliff. And we usually have labeled them as at risk, but actually they're systematically excluded and oppressed. They don't have a fence that prevents them from falling off the cliff. And there's no safety net like the orange people on the other cliff have in case they fall through the fence. And there's no ambulance that works, that has gas, that has a GPS that's functioning, and tires that are, you know, not popped or anything. So again, that's the thing. So the other type of environment, though, since this is a research seminar and y'all have the research programs at UAB and early career people and trainees, it's really important to understand, looking under the hood of the car, that racism and structures and the tree being bent actually permeates the entire research pipeline. And you're right, as was said in the introduction, I've been one of the more vocal people around the bias around JAMA. And that's now one of the reasons why I serve on the editor-in-chief search committee for JAMA. And so we have to acknowledge that whatever research we're producing right this moment, or any research that is currently accruing, like clinical trials, anything, I mean, cancer, you pick it, pick the topic. It's got to be applicable to our evolving demography. I mean, we're a diverse country right now, but 20 years from now, we're actually going to be even more diverse, like substantially diverse, more diverse. And it's really critical that the output of these studies, remember putting in the right input so that we can get the widgets and treatments and approaches for the right generalizable, that are generalizable to the population. So what we put in right now, or as it's going in right now in these trials across the country and the world, need to reflect the populations and how our population is evolving. And so that's a huge issue in the bias pipeline. Part of that has to come from the funder and a stated funding priority, right? So if it's NIH, you know, how is that funding opportunity, or the RFA or FOA written, right? Like our Cancer Center Support Grant, for example, now has a required component of DEI, of diversity, equity, inclusion. That is strategic and intentional and appreciated. And community outreach and engagement, the other component that's been longstanding, is even more important and emphasized. And that's critical to helping to move the field of cancer research and cancer centers more connected with community and the on-the-ground reality of inequities. Who's on the research team is critical. So you're going to see more funding announcements, hopefully, as NIH evolves with its institute-wide strategy for diversity. You're going to see that evolve. So things like OTAs or other transactional arrangements, and things like SEAL, the CEAL, community engagement initiatives, they're going to start morphing more and more. You're going to see more coming down the pike as NIH gets more funding. How that study protocol is designed. So I do a lot in the clinical trials world with ECOG Akron and other NCORE, NCI funded trial sites around how you design a protocol can actually impact whether or not some populations or people participate. And that's really critical to the end results. So all of those things are really important. The other thing is NIH is a federated structure. So you've got like a focus on cancer in one institute, a focus on mental health in another, a focus on, you know, the heart, lung, and blood in another, kidney in another, right? Brain in another, or aging. And there really isn't one institute for women's health. And women's health, as y'all know, you know, crosses multiple institutes, and that's not how the funding works. So that federated structure does not jive, regardless of the existence of an Office of Research in Women's Health. It does not jive with more funding support for women's health or sex-based differences, things like that. So let's consider implementation science and systems thinking, because those are multi-level approaches to science and research that are really critical to moving the needle in health equity. Implementation science is really, I mean, we do this all the time in business. We iterate, right? You plan, do, act cycles or rapid cycle process improvement. Those kinds of things we do on the corporate America side, right? But this is the research side. So it's kind of taking engineering and putting it into medical research, biomedical research. And so that's what that implementation science gap aims to, implementation science aims to do, is to close that gap. Right, so here is a framework that is commonly used, Consolidated Framework for Implementation Research, or CFR. And really what it does is you got to look at all the different environments. There's the internal environment with the individuals on the inner setting, right, of patients, clinical care team, for example, the outer setting, policies, practices, right, and those little arrows on the bottom, the process. The process is what's really critical of what goes on, how you iterate, you deploy an intervention or a little practice change, and you iterate. And it is what that practice is, the process is super critical to improving health equity. It is really about the process and about looking under that hood of the car and trying to expose where systemic racism and structures and barriers and where the tree is bent in as many dimensions as possible to unbend that tree. And it usually requires multiple, there's usually multiple trees that are bent in this whole system. And so you have to work at all the levels of the system to try to really improve one thing, right? And that includes who's on the team, right? So here is a systems thinking kind of thing, things interact, right? There's evidence-based interventions, and we have actually many in women's health. Cervical cancer is a good example of one with respect to screening and follow-up. And you have all of these things at play, right? In the middle of that circle, you have structural racism and health justice, bias models and social norms, effective factual communications, right? We've got the whole syndemic of disinformation going on right now, which is knocking things out, making it harder to actually implement good health care practices. And you have all of these things going on at the same time: people's mental health, the school and childcare, local resources, availability of federal assistance programs, access to certain things like healthy foods and stable housing and physical access to physical activity. You have clinical community linkages and structures and partnerships. So here's an example. It's not meant for you to read, but I want to entice you. You can go to the National Academy of Medicine and look at the Roundtable on Obesity Solutions. And this is a systems approach to what it would take to actually improve the obesity epidemic in our country. It takes a lot, okay? And all of these things are part of the stakeholders and the issues that are required to actually attack obesity. And that's how complicated it is. And so we need people to think like this. We need scientists to think like this and to work across boundaries, right? And to not do business as usual, because the only way we're going to get to improved health for everybody in many different ways, and specifically this lecture is about women's health, is thinking this way and working this way and pushing for opportunities to work this way. So I did mention cervical cancer, and the World Health Organization actually says we could eliminate cervical cancer from this planet. And in the United States, we actually are super poised to be able to do so. But unfortunately, as recognized by Congress very recently last year, the cervical cancer mortality rates have been stagnant for decades in our country. And really what's the issue are these three pillars are not implemented equally or equitably really across the country. HPV vaccination rates are not consistent across the country and completion of that vaccination. Screening is not implemented consistently across the country. And perhaps once we get FDA approval of self-sample for HPV, perhaps that will help promote cervical cancer screening to the areas where it's not implemented consistently or well at all, or to the populations that need it. And then the follow-up and treatment is a huge barrier to trying to reduce our cervical cancer mortality rates. And so it's really important to think about something as, it doesn't seem to be so hard to implement these three pillars like HPV vaccination and cervical cancer screening and follow-up. But even in our own country, we can't get those mortality rates down because we can't do this. And that requires systems approach, systems thinking, and implementation work. And so here's an example from Chicago. So in Chicago, I've done a lot of work on breast cancer and cervical cancer, but here's the breast cancer disparity because it's really prominent. In the early 1980s, the magenta line is the Black breast cancer mortality rate, Black women in Chicago, and the gray line is the white women's breast cancer mortality rate. And in the early 1980s, on the left side of that graph, the mortality rates were about the same. But as we progress in time, as you move your eyes to the right on that graph, in the 90s, something happened. The mortality rate started to diverge. And it's not just about triple negative breast cancer. And it's not about that. In general, by 2007, Black women in Chicago were dying at a rate 62% greater than white women. And I want to emphasize that Chicago has 5 major academic medical centers, gets millions and millions and millions of dollars in breast cancer research funds, and there's lots of community organizations. So something was going on. And we often say, well, New York can't be doing better, but they were. The difference was about 26% in mortality between Black and white women in New York City at that same time period. And in the United States, it was about 42%. So something was really going on in Chicago. And so we had to do a deep dive. We created the Metro Chicago Breast Cancer Task Force and did a media blitz, because media actually is your friend in these types of circumstances, because the aldermen and politicians and mayor and governor want to make the data go away. And you can't make the data go away magically. There's no little Harry Potter magical formula. You have to make good policies, implement good practices, and make sure you've looked under the hood of the car and looked at every single process where the tree is bent, and some populations are being disadvantaged by certain practices. And so looking at this is a social ecological framework. And the inner circle is where there's interpersonal barriers, right? So we deployed a lot of different patient navigation interventions across the city. We had bills that became law that paid for some navigation. And navigation really is supposed to help with distrust that was pretty rampant in Chicago, again, being a very segregated city. Lack of knowledge is a big one. We also did, in the next level of circles, looked at community barriers and health system barriers. And what we did is we followed patients. And so I worked with systems engineers from the business school. And again, they're very good at looking at process and design, systems engineers. And so we followed patients from the time they entered the clinics across the city and some mammography centers to the time they left. And we documented all of those processes ad nauseum and fed them back into the clinical care teams, because there were things that needed to be fixed, processes that needed to be fixed, and really looking at workflow and practices and who gets a mammography referral and who doesn't, and all of that. Some mammography centers, for example, were not giving the results back to their patients. They couldn't find them. And so women were walking around and said they received their mammogram, but never received the results. And they just assumed that they were normal results. So things like that, which are unacceptable, right? And then we did a lot of work in the outer circles where it was advocacy policy. We drafted bills that became legislation. We changed the reimbursement rate from Medicaid lower rate to Medicare higher rate for mammography. Obviously, money helps move things forward. And that was in exchange for centers giving us their quality metrics. So really, these were things that needed to happen all over a decade, right? Patient navigation, I know you all have heard about it. It's an evidence-based intervention now. Back in the day, it wasn't. It's not one size fits all. There's many types of navigation. It's not just individuals, patient navigators connecting, but the important part is there's core principles that it is person-centered or patient-centered, it is community-centered. And again, its core function is to eliminate barriers to timely care across all phases of the healthcare continuum, in this case, cancer care. And it really does incorporate addressing social and economic and political and other determinants of health. It does address helping to bridge distrust and improve communication, which are things that are really important to give care equitably. And those are really important anti-racist approaches into and embedding into healthcare delivery. And so that's really important. The other thing we did is we created a checklist because checklists have been used in many things, like in aviation, for example. That's part of how we have such a great success with secure, with safe flying in the air with all the checklists that the pilots and their team have to perform. And so this is kind of like a Gantt chart. So again, our systems engineers, and we have, this is just one example, we have others. And it basically gets the whole team, right? Because a patient and their loved one or caregiver has to see many different individuals, physicians, nurse practitioners, social work, cancer survivorship care people, dentists, everything when they get diagnosed with cancer. And we put basically the whole team on the same piece of paper. And this literally was a card. It's a thick piece of cardstock. And this is what the front looks like. And it's tailored to the patient, right? And they're what they need. And then on the back, they have the phone numbers of all the contacts. And while this seems simplistic, it is remarkable how much both the care team members and the patient and their caregivers across racial ethnic groups, right now we're working with LGBT groups to flesh this out as well. It is remarkable how much people like this piece of paper. And no, it in parts are getting embedded into electronic health system, but it's not, and it's not an app, but this is just paper. So the other thing that we had to work on was relationship building. And what our patient navigator and those checklists and the individual navigators showed is that you get people, when you deploy a patient navigator intervention, you're not just helping the patient and their loved one or their care team, you're actually getting resources to work together. And so we showed that patient navigation actually fostered and improved relationships among individual community organizations, health and human services organizations, with clinics and hospitals. And this was especially crucial in suburban areas and more rural areas where there wasn't that traditional urban, like Chicago, healthcare safety net. So through a very collaborative and iterative effort and multiple types of navigation across many Chicago area communities, we were able to move the needle. So we closed the gap. So if you start at the 62% on that graph that I showed you earlier, the mortality rate decreased by 2017 and it has been stable around 36 to 38-ish% in the difference in mortality. That's still not good enough, but it took that much effort across multiple people. This is clearly the we and not the me here, to get that gap closed even to that amount. And in COVID, we know that the gap probably has grown again. And so we have a lot more work to do to get that back under control because of the screening and follow-up that's happened from COVID. But the success was predicated on a number of things. We have a lot of different kinds of collaboratives. In addition to that Metro Chicago Breast Cancer Task Force that I mentioned, we have the Chicago Cancer Health Equity Collaborative, which has been going on since 2015, has been crucial in connecting institutions together with our cancer center, crucial with the number of community partners that we're working with on education and research. And we've had all kinds of community forums, and it's just been really critical. We also partner with the Chicago Public Libraries from National Library of Medicine grants around. We created this whole Health for All platform, which is all around clinical trial improvement. There's little vignettes that anyone can access anywhere. This is free and open for everybody. Really critical to understanding clinical trials, learning. We've trained librarians on how to navigate clinicaltrials.gov. So all of these things are really critical, along with navigating wellness for preventive services. And then we also have community scientists that come into our bench in our laboratories, our translational scientist teams, and actually provide perspective. And instead of always going out to the community, I think it's critical to get people in to our labs and our research teams that are translational that don't usually connect with community partners, and have our community partners open up the hood, and they, by golly, they examine under that hood of the car. And we've had some tough conversations and iterations of products that we're trying to build now on that navigating wellness and health for all platforms. And just to give maternal mortality a point, because it's really important, because we also do maternal mortality implementation science work with checklists as well, in addition to the cancer work. We know, and the data 2 weeks ago were released, that it's not even, this maternal mortality rate is actually higher now in 2020. And what's really concerning now is it's not only, there's a about three times difference in maternal mortality between Black and white women in this country, or pregnant and birthing persons in this country, but there's a rising maternal mortality in Latina or Latine persons in this country, and that's concerning too. That's the first time we've seen the data go up. And so we've taken this implementation and system science and checklist design to improve perinatal care, routine perinatal care delivery with our optimized study, which is an R01 from NIMHD. And really the point is to try to see if we can change the cadence and then that checklist that we all use, the ACOG Hollister form for routine perinatal care, to improve and center. We're centering it on Black pregnant and birthing persons across a very large sample across multiple clinics in Chicago. We also have a newly funded R01 in NIMHD to integrate doulas, but also from telehealth approaches, and then honing in on a 5-item checklist. Again, I think this checklist idea might sound simplifying things like prenatal care, but has much traction or potential with respect to consistency of high quality standard of care. And ensuring that, again, intentional is a key word here, ensuring that everybody gets touch points around 5 priority areas that drive severe maternal morbidity and mortality, and that's mental health, cardiovascular symptoms, safety, like intimate partner violence. And we know that in some states, homicide drives the maternal mortality rate, seatbelts, things like that. We know, like that was Louisiana and homicide. New Mexico, we know car crashes drive maternal mortality because they don't wear seatbelts. Opioid substance abuse, which is a huge issue in New Jersey and in Illinois, and social support. The other important thing is not only did our cancer care work inform policy and practice, so does our perinatal care work. And I'm very happy to say that I've worked really hard on helping to draft many drafts, permutations of each of these 12 bills that were in the omnibus, and worked very closely with Congresswoman Lauren Underwood and others on this work that is unfortunately stalled. Most of it is stalled in the Senate. So again, as I close, key points for improving health for women and girls, really to optimize training, mentorship, career development pathways. It's really important. Diversity in the workforce are things that I work on relentlessly. It's very important. Embedding DEI principles into everything we do. And that again takes a lot of strategy and intent. Optimizing community engagement, involvement, and support, and appreciating that there's some changes with respect to NIH, with respect to the Unite initiative to really infuse DEI principles across the 27 institutes and centers. There's the first grant, which I think you all are receiving, which congratulations, that's super incredible and exciting. There's the SEAL grants that I mentioned, and there's other types of work going on across other centers and institutes. So we really do need to understand how to be intentional, really advocating for the structure of things, right? And that includes the structure of funding opportunities to better align the science that's needed on the ground to make health inequities go away. Those are really important. So we want to go here instead of those bumpy roads. And I really encourage you to join me. I am happy to be contacted or follow me on Twitter. Again, I thank you all so very much for this wonderful invitation. And I'm going to stop and open this up for questions. And don't all speak at once. Don't be shy. Oh, Dr. Williams, how
Hi,
are
Dr.
you?
Simon.
Oh, yay! Now I feel really old.
So this is awesome talk and always good to see you and hear from you. We are embarking on, I think, a big overhaul of our obstetric services here. We kind of started on the inpatient side and are moving towards transforming our outpatient OB care to really be payer agnostic. Here, like a lot of places, where patients get their prenatal care is dependent on their insurance status. And so we're moving towards a fully integrated system where patients can go to whatever site is most convenient for them and trying to provide equitable care, I guess, at all of our locations. And but I think one of the challenges that we're seeing and may come up in some of the work that you've done is it's that balance, right, of equity and equality. And so kind of specifically thinking about obstetric services, where we're trying to get everyone to the same level, but still provide those specific needs, I think, that some of our patients in different communities, right, because we're serving a whole lot of different communities here across the city. Any insights into, how we balance that as we're embarking on this big change?
Yeah, I mean, I think it takes the support of leadership to back y'all up. That's really important. And it takes being honest and open that it's not going to happen overnight. And that the process, like I said, is really critical to getting and going along that journey is really critical to better understanding how to do it. And look, we still have a long way to go back in Chicago and specifically at Northwestern with respect to that type of integration. And so again, being open and honest about what we can do first and what we can do second. And maybe this is our big goal, a couple of years down the line, but I think progress towards that can be done, right? So really thinking about how you structure the panels of patients, which ones you can integrate first easier than others. The other important thing is the clinical care team, staff, everybody on board with that. Are they ready for more diverse people and backgrounds that may not have entered the clinics before? So understanding it's not just opening up the doors and saying, we accept all patients, but then you've got to have a clinical care team and support services to attend to the patients and tend well, that are trained and not going to create more bias, if you know what I'm saying. So all of that needs to come with that evolution. I mean, that without like getting too much into the detail that I can't get into because I don't know, hopefully is a little helpful. But you can't change this overnight. This is not something that you just snap and go, okay, we'll accept all payer mixes, right? That's not reality, right? And your chair and others need to advocate as well, and that it becomes a process, right? An evolution. And I think that's one thing that when I'm working with the residents who want things to change yesterday, and appropriately so, there's a process to everything. And the bulkiness of our healthcare delivery system doesn't help that process any.
Dr. Simon, my name is Margaret Boozer. Thank you for this.
Sure.
I am amazed and applaud the work that you all have done in Chicago, and know that so many of those disparities exist here for us. The question I would have for you is that, you know, as we work to address disparities, as you mentioned, patient navigation and identifying community partners and better engaging in communities, they're very, like you said, evidence-based, but how well you do them really matters. And I feel like there are hot button phrases that people love to say, we've got community partners and we've got community investment, but can you speak to how, like, recommendations as far as how we might effectively and truly appropriately to the community achieve that?
Yeah, I mean, it's you're right that there's these what I would call so-called tourists in community engagement partnership, just like there are some tourists, as I've been on the record for in health equity work. But I think that comes with time. It building trust, and it takes time. And the most important thing first is to build on the relationships that you already have that are in existence, and having honest, super honest, open conversations about what is going right and what is not. And my community partners, for example, have no problem telling me exactly what they feel at any time. Like, there is no, I do not want anyone to just say, oh, it's great, this is wonderful. No, I want honest, open feedback. And that is really critical with any relationship. And there's no playbook on how to do that other than being human and being relatable and being humble, and understanding that just because you're from a fancy institution, you know, like I'm from Northwestern, Neiman Marcus is literally next door to our hospital. And so we share the same initials, Neiman Marcus Northwestern Medicine. And I am fully aware that the privilege that exudes from our hospital and being at Northwestern already makes the power dynamic in any relationship or partnership off. And so I work really hard to meet people where they're at and partners and really want that feedback. And I think that's, if everybody understood that kind of common thing, common approach, I think we'd do a better job of trying to then bring it in. But I will tell you, there's no number of community advisory boards or, community steering committees that are going to get us out of being racist or discriminatory in our practices, right? It really is about that genuine nature of the partnership and to help acknowledge that there's expertise from the community partners. And that expertise needs to be recognized, supported, acknowledged, paid for, compensated, and embraced. And at the same time, we have expertise too, right? We can help in certain ways, but that balance and that harmony is what's critical. I see a lot of missteps with respect to, well, you need to partner with us and we're the almighty Northwestern or whatever, and we know what we're doing and we'll save the world. Well, that doesn't work. If it had worked, we wouldn't have these disparities. So I don't know. I mean, I think what you're asking has so much complexity to it. And because every relationship that you enter in is a little different. And not all people are programmed that way to engage with different groups and different people naturally, especially when you're trying to incorporate that into a healthcare practice or delivery or a research project.
Thank you for that. Thank you.
Thank you. But I know there's many people, including some on this call, that do it really well. I know that because I worked with them.
Hey, Melissa, it's Rachel. Thank you so much for speaking with us today. We appreciate it so very much. So thank you for sharing your Friday afternoon with us. I wanted to pick your brain a little bit about maternal mortality. You know, our rates in Alabama are just unacceptably high. And any wisdom you can share about any innovative programs or processes that have worked in Chicago?
Yeah, I mean, like I said, I mentioned those two programs that we're working on now. Again, I think I would say that our perinatal quality task force is really strong, and I know yours a little bit, and I work with some of your team members, and I appreciate all that they're doing to try to like advance the work. But I would say for maternal mortality and for severe maternal morbidity, that work really does need to be tailored locally. There are certain things we can do across the country, like the two studies that I talked about, the improving the perinatal care delivery and improving the routine perinatal care delivery, like trying to modify the cadence of visits. Like, you know, I don't believe that one initial prenatal visit should be as packed as it is. I actually think there should be two initial prenatal care visits. I think it should be the amount of stuff that we throw at a patient, whether it's a new cancer patient or a new pregnant person visit, we throw way too much stuff at folks. And even like somebody as educated as I am, receiving that amount of information and being at the same time with all of the circumstances that I come to that clinic visit, it could be, you know, my dog died. It could be it could be much worse than that, right? I can't pay my bills. I'm going to get evicted. When you have that mindset and you're coming in for that first prenatal care visit, there's no way that information is going to flow. There's no way. And then you start talking about a COVID vaccine or a Tdap or a flu shot or a diabetes screening. That's way too much stuff. We got to build trust. Why isn't the first visit all about what are your hopes and dreams of pregnancy for this pregnancy? What are the things you fear most? What are the things that we can help you with, right? What are the things you want us to address, right? Why isn't that the first prenatal visit, right? And then in 2 weeks, bring them back. all right, or 3 weeks, whatever the cadence is, it can be tailored, but why not? And then when people leave the hospital with their baby in tow, there should be a phone call follow-up 1 week later, a safety check, right? Just to check in, how you doing, right? Because we all know you're in the throes of like this living thing, and you're tired and you're taxed to the maximum with all the other circumstances that you have. Those kinds of things, that real life experience, we need to incorporate that better into healthcare delivery, right? You know, the business world, they talk about life experience and what it's like on the ground for their products, to get their products to sell better. Well, why aren't we doing that for healthcare design and delivery? The same thing for that other study that we're doing is trying to distill a touch point, a set of 5, right? I had this idea of a dream of partnering with places like Walmart and stuff, where most people visit more than a healthcare provider. And that checklist of 5 things that I talked about, like you get the cardiovascular, like a blood pressure check, a mental health check-in, a safety check, support. If that could be infused in different ways, like in different places and spaces, and perhaps we'd have a better chance of catching some severe maternal morbidity before it progressed to mortality, right? If we think outside of the box and really get down to the real lived experiences of patients, of our patients from all types of backgrounds, we actually have a better chance of impacting health. Right? Think about it. When you bring a new child home, I have 4 kids, so I always think about children. But when you bring the new child home and you haven't done this before, you need to safety proof your environment, your apartment or your condo or your house, right? And you need to like actually crawl on your hands and knees to figure out where are the hazards, because you know that's the level that they're going to be at. Well, why aren't we thinking about that, right? Walking in people's shoes, understanding, trying to really incorporate the lived experience into that healthcare delivery setting. And I think that would bode well for both improving cancer care delivery and perinatal care delivery and all the other stuff.
Thank you so much, Melissa.
Sure. I talk a lot. I'm sorry. Well, it's so good to see friends on this call, including people that I have helped train.
Melissa, thank you so much. Really enjoyed your talk. Fantastic. I think we can take up some of this. It's Alan. I think we can take up some of these ideas with opportunities that are immediately available as we speak. Thank you.
Absolutely. Absolutely. It's good to see you, Ashley. Well, I'm not seeing you, but I see your square. It's so cool to see people. There you are. It's so cool to see people that you've trained or had some little piece in that training. I really appreciate y'all taking the time on a Friday afternoon. I hope you all have a great weekend. Take some time for yourselves.
Thank you. You as well.
Thank you.
All right. Bye-bye.
Thank you, Melissa.
Thank you. Bye-bye.